Hello, my name is Niall McKay, and welcome to Living with PSC, a podcast about the rare disease of primary sclerosing cholangitis. Now, PSC causes the bile ducts inside and outside the liver to become scarred, narrowed, and eventually blocked, and leads to liver cirrhosis. In this podcast, we aim to dispel some of the myths about the disease. Today, we're talking to Dr. Julie Heimbach. She is a transplant surgeon and the department chair of the transplant department at the Mayo Clinic in Rochester, Minnesota. And today we're talking about the ins and outs and the intricacies, if you will, of transplants for PSC patients. Can you tell us just a little bit about the disease of primary sclerosing cholangitis and how you come across it in your daily life?
So PSC is a disease that affects the liver, and in particular within the liver, the bile ducts, so that they become injured. We don't know the exact cause of it, but it does seem to have an immune-mediated component, and the bile ducts become progressively scarred, so that the drainage of the bile, which is a fluid made by the liver, does not happen in the normal way. And over time, that causes ongoing injury to the liver. And for some patients, advanced liver disease, liver failure, the need for transplantation, which at this point in time is the only curative treatment that we have.
One of the things that I often hear from PSC transplant patients is that when you guys get the old liver out, it seems to be in a lot worse shape than anybody had imagined. Is that normally the case?
Yes, I think one of the more this is maybe is anecdotal, but I feel that patients with PSC seem to tolerate more advanced disease better than patients with other types of liver disease, such that they don't really realize how sick they are. And then when they're transplanted, they seem to be so surprised at how much better they feel with a transplant. So I think it may be because they tend to be younger at the time of diagnosis, younger at the time of transplant, so that the rest of them is so strong that they can perhaps put up with this. But I think that is the surprising thing. It's definitely true. The liver definitely just to the eye looks worse, but even the patients experience an improvement in their physical health more than they would have anticipated. They didn't really realize how sick they were.
Now, one of the things that people often say, or transplant patients often say, or people say to transplant patients, is that, are you on the list? this list. Can you tell us what the sort of progression is to that list and when one goes on it?
Yeah, that's a great question. And in the United States, it's important to recognize that being listed for transplant does not have the same importance as it once did. A very long time ago, the system essentially defaulted to waiting time. So it was important that patients got on the list early on, because at some point they would need a transplant, and they would have accrued all this waiting time that would be beneficial to them to put them at a higher priority. But really, since 2002, we have not allocated based on waiting time, but rather based on the idea of urgency. The sickest patient goes first. And so there is not actually a need to be listed until you actually need a transplant. I think it's very important to make sure you've got an established care with, a liver specialist, and, not necessarily bad to be evaluated early, so that when you become sick where, how it's going to happen and where you're going to go. But in terms of actually being listed, it actually does not benefit anyone to be listed until the symptoms have progressed to the point where transplant is something that is likely to be happening in the near future. So that's an important thing to know. Being on the transplant list means that you've gone through an evaluation, you've been accepted to be placed on the list. You've been placed on the list, and that evaluation is important to make sure that there's no other underlying condition that would impair your ability to have a successful transplant, such as an undiagnosed heart problem or some other issue related to that.
Therein lies the rub. Sometimes progression for a PSC patient can be very quick.
Yes. Yes. And that's why I think it's very important that you have established, you know, you have a liver doctor and, a connection potentially to, what the next step will be when you need a transplant. And, the timing of when you should go and undergo a liver transplant evaluation is definitely going to have to be individualized. You don't want to be coming to the transplant center too late. But on the other hand, there's really not a need to come too early. It's a little bit of the Goldilocks, problem, finding it to be just right. And that sweet spot is sometimes, it's different for every patient.
And PSC patients are more likely to present with cancer and stuff like that.
Yes, so that's a very important concern for patients. Anybody with cirrhosis, which is scarring of the liver, is at risk for malignancy, primary malignancy of the liver, like hepatocellular carcinoma. That can happen in any patient with cirrhosis, but PSC patients are at risk for a particular kind of liver tumor, even in the absence of cirrhosis. And this is a tumor of the bile duct called cholangiocarcinoma. PSC is one of the strongest risk factors for the development of that disease. That disease is very challenging to diagnose and even more challenging to treat. Some patients who develop cholangiocarcinoma in the setting of PSC may still be eligible for transplant, but it would be essential that we identify it early so that it would be limited, so that it's just contained within the bile duct of the liver, not spread, because transplant would not be beneficial if it had already spread. So that is a very big challenge in patients with PSC. The chance that you would develop that bile duct cancer in the setting of PSC is not common. It's about 2% per year, but that's far more common than the risk of getting cholangiocarcinoma, in the absence of PSC. And in the long term, patients with PSC, sort of lifetime risk in the neighborhood of 20%, after having the diagnosis of PSC, in the neighborhood of 30 years.
Oh, I see. So they have a 20% higher, or they have a 20% chance of getting cancer of the bile duct if they're diagnosed with PSC.
Well, depending on, the timing of it. So each year of diagnosis, you would say that there is a risk for each year, so that cumulatively, say at 10 years, your risk could be in the neighborhood of, between probably 6 to 12%. So in between there at 10 years. And then if someone who has lived 30 years with the diagnosis of PSC, their risk is upwards of 20% of those patients will have developed bile duct cancer. So it's a significant risk, but it's not every single patient with PSC.
I see. So it's like it's on a sliding scale.
Yep. And interestingly, there seems to be an association, within the first year of diagnosis of PSC, there is a sort of a spike of also having been diagnosed with bile duct cancer. And it may be that the patient had PSC for, significantly longer time. It just was not diagnosed. So, that's not certain how long they had PSC before they were diagnosed with cancer. And maybe it was the cancer that brought them in, but and of course, then we would also discover that they have underlying PSC. But, in upwards of 30% of the time, they're diagnosed within 1 year of each other.
Oh, I understand. So often, probably they're having some kind of problem that they come to the doctor with. Cancer is sometimes discovered.
Correct. Yep.
This is the other difficulty with PSC, isn't it? Are there particular markers that people can watch out for with cholangiocarcinoma?
Yeah, so that's a very big challenge is how should a patient with a known diagnosis of PSC undergo screening? What is the appropriate, testing that should be done every year? And, how do we watch these patients? And, it's not like breast cancer where we know, everybody should have a mammogram on this time frame. It's much more challenging than that. But clearly, follow-up is important. Monitoring the patient's clinical status. Anytime there's a change in their clinical status, like becoming more jaundiced, that would be an important time for the patient to undergo further evaluation. What would be the role of imaging? This is something that strategies that people do develop. Individual hepatologists develop their own strategies, but I think having a systematic way for the patient to be followed is important, but it's not well established exactly what that should be. Many places do undergo screening, imaging exams at a certain interval, and whether you should also have, what the markers should be. There's not a great marker, but there are markers that are helpful. There's one called the CA19-9 that is typically followed, but it can be normal in some patients even when they have bile duct cancer. So it's not a perfect test either. So I think a lot of work is being done and trying to make improvements in the ability to make a diagnosis earlier. And hopefully some of those new techniques will be beneficial.
I presume, though, it would be a number of factors.
Yeah, the primary way to make the diagnosis still is imaging. Taking a cross-sectional image with either a CAT scan or an MRI test. This is the most helpful. Also, going inside of the bile duct with the ERCP, which is a special scope that can go inside of the bile duct and put dye in there and look and see how the bile ducts, fill up with the dye, and then also they can place a small little instrument inside there and take a little brushing sample of the lining of the bile duct. That can be very helpful. The serum blood test that I mentioned already, the biomarker test called CA19-9, is a test that we can do, but it's not a perfect test, and that it's not perfectly sensitive and not perfectly specific either, because it can be elevated in the setting of just having an infection in the bile duct. So it's not perfect by any means, but that combination of watching for a clinical change, taking a cross-sectional image, checking the serum biomarker and laboratory tests, and doing the ERCP, that's sort of the combination strategy that putting those things together can be helpful.
What is the difference between a live donor and other transplants?
Yeah, so how does once we've made a decision that it's time for a patient to proceed to transplant, then we need to make a decision of how we're going to be able to access transplant for that patient. And for any patient who needs a liver transplant, in the United States or around the world, the, primary limitation to that is, that we don't have enough livers for all of the people that need them. In the United States, the number of waitlisted patients is, approaching 15,000, and the number of livers that we have available each year from what we call a deceased donor is, just over 7,000. So not nearly the number that we need compared to the number that we have. And so the priority for the transplant is based on, as I mentioned earlier, this idea of urgency. The sickest patient is prioritized first, and that is based on this score that we can calculate from the patient's lab tests, just regular old blood tests that we get that can tell us how likely is it that the patient will die of their liver disease in the next 3 months. And so that's the MELD score, and that number is actually quite good at predicting that endpoint of being dead or alive in the next 3 months. But for many patients with PSC, they have a lot of suffering, a lot of difficulties with ongoing infection in their bile ducts, and being jaundiced and losing weight and having a lot of itching and other symptoms. Yet their survival is actually okay on the wait list, even though they're still having all of these really difficult symptoms. So they won't be high on the list because of their ability to continue to survive with their disease, because the disease is really, or the score is really based on your likelihood of dying or not dying of your liver disease. And for PSC, it tends to be one where the patients can still keep going. So yet their quality of life is very poor, and their ongoing hospitalizations and other issues that can happen to them would make transplant, I think, a very important consideration. And so in that setting, when you're not having a high priority for deceased donor transplant, that's the ideal time to consider the possibility of living donor transplant. The primary advantage of living donor transplant is the ability to control the timing of the transplant, so that you can move forward with transplant when the patient's symptoms really can't be controlled with best, medical management. That's the time to think about moving forward to transplant, or obviously in the setting where we've made the diagnosis of cancer, where then it would become imperative to proceed to transplant. And living donor really allows us to do that in a timely way without the patient continuing to have us suffering or being at risk for, severe complications on the wait list that could lead to their death. So what we know about living donor transplant is that clear survival advantage when we measure from the time that the patient comes to the transplant center. Those who are able to proceed to transplant with a living donor have the best outcome overall. Those that are, go on the list and have to wait for a deceased donor have, this, second best outcome. And those that are not able to proceed to transplant have the worst outcome. And so the reason for that is exposure to things or troubles that can happen to you while you're waiting on the list. If we measure this outcome from the day of the transplant, the outcomes are almost equal. The living donor grafts are still maybe slightly better, but in general, pretty similar outcomes for living and deceased donor transplant. But if we measure from the time of coming to the transplant center, there's definitely an advantage. So the first difference is controlling the timing and how that can lead to a survival advantage for someone that can proceed with living donor transplant. That's the primary benefit.
When you're talking about the liver donor transplant, you're talking about taking out the whole of the PSC patient's liver and replacing it with, say, 20% of their brother's liver, or
Right. So that's really important to understand is we do the transplant exactly the same way, no matter what kind of liver we're putting in. If we're putting in one side of a healthy person's liver, or we're using a whole liver that comes from a deceased donor, independent of that, whichever kind of liver we're putting in, we're still going to do the transplant the same way. We're still going to take out the entire liver. We're still going to put the new one right in the same place and make all the hookups that the liver has. Right now, we would just unhook the important connections to the liver, take the old one out, put the new one in the exact same spot. The reason living donor liver transplant works is when you look at a liver, it looks like it's just one big thing, unlike a kidney where people clearly have two different kidneys, and it's easy to understand how they can donate one of them. The liver, it looks like on the outside, it's just one thing. So it's hard to understand how you could take out part of it. But on the inside, it actually does separate quite well into a right and a left side. And it is possible to remove one side of a healthy person's liver, including all of the structures that supply that side. So if you think about it, they all have things coming in, big structures, a portal vein, a artery, a bile duct coming out, and an outflow from the liver. All of those things have a main trunk, just like a tree has a main trunk coming in and coming out, and then it branches just as it comes into the liver. So we just remove the branch to that one side of the liver plus that one side of the liver, leaving the donor with the main trunk and then the branch to the other side. So what happens for the donor is their liver, the part that stays in them, grows back to a whole size liver very quickly, actually. In a matter of weeks to months, it's basically back to full size. So when we do the living donor transplant, the part that we give to the recipient somehow gets the signal to grow to the size that the recipient needs. So in the case where the donor is quite a bit larger than the recipient, it doesn't grow to that larger size, particularly important in children. When we take part of an adult liver and give it to a child, it doesn't grow back to an adult-sized liver inside of the child. It grows to the size that the child needs. And even in adults, it does the same thing. It can even get bigger than it was originally if the recipient is slightly bigger than the donor. Somehow the liver does get these signals to regenerate, which is really amazing. And that's how this works, is because the liver has this ability to grow itself back again. So both in the donor and in the recipient, this regeneration process is essential. And that's why this is possible.
we talked about the outcomes that donors can expect.
Yeah, so we talked about the benefits. What we did not talk about is the downside of living donor transplant. And I think there are two, really important downsides that we should highlight. Most importantly is, of course, we have two patients to be worried about now instead of just one patient. So in a living donor transplant, we have, of course, the recipient who will be having a transplant and hopefully will be having a good outcome, but they have to have, of course, a big surgery. But also now the donor is going to have a major surgery, and that donor would be also at risk for complications from the surgery. They will have to be off work. They need to recover from a major surgery, and all of the considerations that go with that, which are not there when we can do deceased donor transplant. We don't have two patients in the hospital in that situation.
And is there other downsides? What are the other
So
downsides?
the other downside is all of those things that we connect, the artery and the portal vein and the bile duct and the hepatic vein, they're all now going to be half as large, because what we're hooking up, instead of hooking up the main trunk, what we're making a connection to is the branch. So all of these are smaller connections. And most of the time it still goes quite well. But in particular, the connection for the bile duct is more challenging in this situation, because as it heals, it can make a scar, which is sort of a normal process of healing. But when you have a really small tube and it makes a little bit of a scar, it is more likely to be clinically relevant than when you have a larger tube, like a larger trunk, the whole size bile duct, as opposed to half of the size bile duct. So we would have more chance of having trouble with that bile duct healing up, so that it leads to what we call a stricture, or a scarring right at the connection for the new bile duct. And that is definitely more likely to happen when we're doing a living donor transplant than a deceased donor transplant. We have a way to manage that, so that we can solve that problem when we get it, but it can take quite a bit of intervention to get that problem solved.
Uh, and does that involve stents, or how do you?
Yep, it does. So typically those stents would be placed oftentimes with a scope. The patient would be having anesthesia. They would put the camera down into the intestine and then up inside of the bile duct, leaving that little stent in there that would stay in for a period of a couple of months, and then take the stent out, check it. If it's still narrow, they'll put a balloon in and stretch it a little bit more, put the stent back in. Usually it takes a couple of stretch treatments from these balloons and stretching, and then leaving the stent a couple of times before we can get that to heal up without having a scar. Although usually that can happen. We won't need to have stents in for the long term, but just for a period of time.
And therein also lies the rub, because one of the, if you like, treatments for when you have PSC, an infection or a blockage, is to use ERCP, isn't it? And there are complications with using ERCP.
Yes, there are. It's a little bit of a different kind of ERCP after transplant, because the connection is a little bit different. But yes, and it's interesting to be thinking, well, we had a transplant to begin with because my bile duct had all these scars in it, and now I've got another scar in it after transplant. But it's important to recognize it's a different kind of scar. The scar, or the narrowing that happens in the bile duct with PSC, is usually more than one area, so it's a diffuse bunch of scars inside of the bile ducts, as opposed to a single narrowing right at the hookup that then would be more amenable to a treatment with the endoscopy. Whereas PSC, it's we can sometimes get a really good benefit with the ERCP, but a lot of times there's really not a great benefit, because it's not just one area that we have to treat, but it's multiple areas, and we can only fix the one area, and there's all these other areas that are still trouble.
And can you talk a little bit in general just about the problems with the ERCP? Just it can spread infection and do some other things. Can injure you a little bit. Can it when it's?
Yeah, so the actual process of putting down the scope in someone that has never had it done before, there's a little sphincter, a little kind of, you think about it as almost like a little muscle that is trying to keep that bile duct from being, in free communication with the inside of the intestine. And the first time you put the scope through there, you usually have to, stretch, or even, do a little sphincterotomy, a little cut in that muscle, so that the scope can get inside of there. And then after you've done that, now it's a little bit more open to the intestine. So that sphincterotomy has sort of changed the connection a little bit just by itself. So driving the scope in there the first time can make that different. Going into the bile duct, then there's another duct right there called the pancreatic duct. So that's where the pancreas joins in there, and driving the scope by the pancreatic duct can lead to irritation and and swelling and blockage of the pancreatic duct. That can lead to a problem called pancreatitis, where the pancreas gets really upset and irritated, and that is a difficult problem that can sometimes even require hospitalization and the patient not being able to eat and, being pretty sick for quite some time. That's
Sorry,
a
doctor.
possible risk of having an ERCP. These risks are not necessarily the same right after transplant because the hookup is, as I mentioned, a little bit different. But still, anytime the patient has to have any kind of a procedure involving really anything, there's always risk.
Well, great. Is there anything that I didn't ask that I should have asked, or anything you want to add?
Well, I think one of the challenges that we still haven't solved is, of course, understanding why patients get PSC. And then, of course, there's still a risk that the PSC can come back after transplant. So what we're really hoping is to understand why patients get it to begin with, and also why, in some patients, not even most patients, but just some patients where it can come back after transplant. Obviously, we don't like to put people through a big surgery and have them be at risk for the same disease coming back that they had to go through this big surgery for. So, hopefully we can continue to make progress and solve this. I'm sure that we will. It's just a matter of, timing and when that will happen.
It seems there's a lot of work being done with the microbiome and the connection between the gut and the liver. That seems to be.
Yes, I think that and several other promising areas, related to the immune system and how it is making a reaction. I think all very hopeful, and we'll just have to definitely keep making a focus on this. And now that another major liver disease, hepatitis C, has very, very good therapy that is curative therapy, hopefully we can make progress in some of the other liver diseases.
Well, I don't want to keep you from your essential job, which is saving lives. We very much appreciate your contribution here to PSC Partners, and also, the work that you're doing on a daily basis.
Neil, it's really nice to talk with you. Thank you so much. I appreciate it very much.
Well, I'm afraid that's all the time we have for this week. For more information about PSC and for a list of people and topics we'll be covering in the near future, please go to www.pscpartners.org. That's www.pscpartners.org. PSC Partners is a non-profit organisation dedicated to providing education and support to primary sclerosing cholangitis patients. There is information and resources on the website. There is a conference once a year. There is a private Facebook group that you can also join. Also, please join our patient registry. This is an anonymous database that provides research support to the medical community who are researching this disease. Thank you very much for listening.